Welcome to the presentation on health policy, health quality, and health information technology. The learning objectives for this presentation are to identify the current challenges in healthcare quality and examine the components of the healthcare system that have an impact on quality. The national mood is reflective of a complex healthcare system that is plagued by exorbitant healthcare spending and quality and safety concerns. The National Coalition for Healthcare reported that total healthcare expenditures make up 16% of the gross domestic product and are expected to reach $4.2 trillion in 2016. The NCHC also reported that there were more than 47 million uninsured Americans in 2006, and that this number has risen by almost 9 million people since 2000. As a response to these problems, the Affordable Care Act was signed into law March 23, 2010. This law has brought health information technology to the forefront as an indispensable tool and ensures comprehensive changes to the current healthcare system, placing emphasis on the role of quality improvement and health information technology in the system. Some of the changes from the Affordable Care Act include increased health coverage for children, a health insurance mandate, ending lifetime and most annual limits on care, allows young adults under 26 years old to stay on their parents' health insurance, and gives patients access to recommended preventive services without a cost. The Act also includes other benefits, such as 50% discounts on brand-name drugs for seniors in the Medicare, quote, donut hole, and tax credits for small businesses that provide insurance to employees. Donald Berwick, the former chief of Medicare and Medicaid, is a prominent leader in healthcare quality and the founder of the Institute of Healthcare Improvement. He has dedicated his career to improving patient outcomes and providing better healthcare at a lower cost. In a speech to the Harvard School of Public Health, Dr. Berwick said that system performance depends not only on the elements of the system, but on the interaction among these elements. He goes on to say that healthcare improvement depends on systems thinking and redesign, and that healthcare reform without attention to the nature and nurture of healthcare as a system is doomed. To quote Dr. Berwick, "It will, at best, simply feed the beast, pouring precious resources into the overdevelopment of parts and never attending to the whole. That is, care as our patients, their families, and their communities experience it." As part of understanding the current healthcare landscape, we are going to review 3 programs that have profound impact both in the use of health information technology and the quality of the healthcare system. The first of these programs is Meaningful Use, in which providers show they're using certified electronic health record technology in ways that can be measured significantly in quality and in quantity. The second program, the Patient-Centered Medical Home, has providers organize care around patients, working in teams, coordinating care and tracking over time. And finally, the Accountable Care Organization component ties provider reimbursements to quality metrics and reductions in the total cost of care for an assigned population of patients. The Obama administration has continued to respond to a national call to have computerized health records by 2014. The American Reinvestment and Recovery Act of 2009 authorized the Centers for Medicare and Medicaid Services, CMS, to provide reimbursement incentives for eligible providers and hospitals who can demonstrate that they use certified electronic health records in a meaningful way. This act has a health information technology for economic and clinical health provision to establish programs under CMS in coordination with the Office of the National Coordinator. Meaningful use has been defined as the effective use of information to support better decision-making and more effective care processes that improve health outcomes and reduce cost growth. Meaningful use has 3 overarching goals. The program aims to enhance data capture and sharing, advance clinical processes, and improve outcomes. Meaningful use of electronic health records means that use of these records improves quality, safety, and efficiency of care, engages patients and families in their care, improves coordination of care, and improves population and public health, and reduces disparities. It also ensures privacy and security protections for all. To qualify for federal incentives, users of certified electronic health records must demonstrate that they meet these criteria. Meaningful use criteria was released in 3 stages. Stage 1 criteria are directed toward capturing and sharing data. The objective of Stage 2 criteria is to advance healthcare processes with decision support, and in Stage 3, meaningful use criteria will be targeted at improving outcomes. Stage 1 criteria address the priority of improving quality, safety, efficiency, and equity of healthcare. The goals of Stage 1 criteria are fourfold. First, in order to meet the Stage 1 criteria, health information must be electronically captured in a structured and coded format by both hospitals and eligible providers. The goals of Stage 1 include capturing health information in a coded format, tracking on key clinical conditions, promoting care coordination, and reporting of clinical quality measures and public health information. The goals of Stage 2 are to build on Stage 1, use clinical decision support to improve performance, and promote web-based access to personal health information. And Stage 3 further builds on Stage 2. It promotes health information exchange through comprehensive interconnectivity and promotes broader access to patient records and develops enhanced reporting capabilities. Stage 1 criteria address the priority of improving quality, safety, and efficiency and equity of healthcare. The goals of Stage 1 criteria are fourfold. First, in order to meet the Stage 1 criteria, health information must be electronically captured in a structured and coded format by both hospitals and eligible providers. Then they must be able to demonstrate that they use that information to track key clinical conditions for quality improvement purposes. Third, providers and hospitals must be able to communicate that information to other care providers to ensure coordination of care. Then they need to lay the foundation for reporting clinical quality measures and public health information. Criteria have been divided into 2 sets, a core set that must be met by all eligible providers, hospitals, and critical access hospitals in order to qualify for incentives, and a menu of additional criteria from which they must select any 5 choices to receive incentives. Stage 2 builds on Stage 1 by refining the measures. For example, hospitals and providers are required to permit patients to view online, download, and transmit their personal health care information, use CPOE for a higher percentage of medications, labs, and radiology, electronically record demographics on a higher percentage of patients, and enter electronic progress reports for patients. And Stage 3 further builds on Stage 2 with a particular emphasis on improved outcomes and health information exchange. More than 60% of the measures require interoperability. That's up from 33% in Stage 2. Clinical quality measure reporting is aligned with the Centers for Medicare and Medicaid Services quality reporting programs, and it promotes the use of application program interfaces, or APIs, to build bridges across systems and provide increased data access, especially focused on patient access to their own health records for improved decision making. Now, shifting gears, we will cover information on the patient-centered medical homes. The Patient-Centered Primary Care Collaborative, the PCPCC, is a group that includes consumer groups, hospitals and providers, large employer groups, and many others, joined together to focus on the patient-centered medical home, PCMH. This group has formed to advance the concept of the PCMH and puts forth the following definition: an approach to providing comprehensive primary care for children, youth, and adults. The PCMH is a healthcare setting that facilitates partnerships between individual patients and their personal physicians, and when appropriate, the patient's family. The American Academy of Family Physicians, the AAFP, the American Academy of Pediatrics, AAP, the American College of Physicians, the ACP, and the American Osteopathic Association, the AOA, in 2007 created a set of joint principles that outline the characteristics of the PCMH. These 4 groups have a total membership of more than 33,000 and have a vested interest in the PCMH model. The Joint Principles document can be found on the website of the American Academy of Family Physicians. There are 7 principles that have been put forth by this consortium of 4 groups for the PCMH, and we will briefly describe these 7 principles. Here are the first 4 of the 7 principles. The first principle asserts that each patient has a personal physician who becomes the captain of the ship, taking total responsibility for a patient's care. The second principle is the physician-directed medical practice. This principle espouses that there is a team of individuals led by a physician who take total responsibility for a patient's care. A whole person orientation, the third principle, means what it says. The person is viewed as a whole, not a collection of systems or illnesses. In the PCMH, this principle means that all aspects of the patient's healthcare needs, across all stages of life, is the personal responsibility of the primary physician. The personal physician must also assume responsibility for arranging and coordinating care for a given patient. The fourth principle assures that there is a coordinated and/or integrated across all sites of care, including acute care, home care, long-term care, in the community, and the like. Such care assures smooth, continuous, and culturally appropriate care. Of course, the ability to provide such continuity and coordination is reliant on health information technology, mechanisms for health information exchange, and a patient-centered focus that takes into account culturally and situationally appropriate plans of care. The final three dimensions start with quality and safety, which are the fundamental and defining characteristics of the patient-centered medical home. The goal of the PCMH is to support and encourage attaining patient-centered outcomes. These are not the outcomes decided by the provider. Instead, these are commonly derived goals between the care team, the patient, and his family. It requires compassion and strong relationships between all members of the patient-centered team. It also requires that the patient and family expectations for the care process and the outcomes are being met. Quality and safety measures also include adhering to evidence-based practice and the use of robust clinical decision support tools to guide optimal decision-making. Achieving quality and safety also requires that all members of the team, with the feedback from patients and families, participate in continuous quality improvement and voluntarily participate in quality improvement measurement and reporting. Interestingly and quite relevant for health information technology professionals, these guidelines under the quality and safety header require the use of health information technology to facilitate high-quality communication, measurement of performance and outcomes, to support superior patient care, and for patient and family education. Finally, demonstration that the practice has the capacity and wherewithal to provide patient-centered care consistent with the PCMH determined by a voluntary recognition process conducted by a non-governmental entity is required. The sixth principle of enhanced access to care is directed at assuring that the patients are able to reach providers and care staff with a minimum of effort. This can be achieved via the use of health information technology, such as online scheduling, emailing with providers, much in the way that the Veterans Affairs My Healthy Vet web portal works, or by other methods such as weekend hours, evening hours, and the like. The seventh and final principle focuses on payment. The payment principle is premised on the acknowledgement of the value that is derived from patients who are participating with the PCMH. A payment structure has been derived as part of the framework and includes aspects such as payment for care coordination, financial incentives for adoption of health IT. Recall, these principles were developed in 2007, long before the HITECH Act. Payment for remote monitoring activities and the use of alternative telecommunications with patients and families. Attention to case mix. Allowance for enhanced cost sharing across providers for cost savings derived from the PCMH, rewards for achievement of high quality and low cost services, and several other aspects. The entire payment framework can be found by accessing the reference at the end of this slide deck from the AAFP. In addition, these entire 7 principles of the PCMH are very clearly outlined in the same reference for students to examine in closer detail. The principles just outlined translate into specific elements that healthcare delivery sites have to put in place to be part of this system. This slide presents an example of elements and their scores necessary for the NCQA certification. This is one of the many PCMH certifications, and it presents a good example of the specific elements. The Enhanced Access and Continuity Standard accrues 20 points in the following elements. Access during office hours, 4 points. Access after hours, 4 points. Electronic access, 2 points. Continuity, 2 points. Medical home responsibilities, 2 points. Culturally and linguistically appropriate services, 2 points. And practice organization is equal to 4 points. The Identify and Manage Patient Population Standard accrues 16 points in the following elements. Patient information is worth 3 points. Clinical data, 4 points. Comprehensive health assessment, 4 points. And using data for population management is worth 5 points. The plan and management standard accrues 17 points in the following elements. Implement evidence-based guidelines, 4 points. Identify high-risk patients, 3 points. Manage care, 4 points. Manage medications, 3 points. And electronic prescribing is worth 3 points. The Provide Self-Care and Community Support standard accrues 9 points in the following elements. Self-care process is worth 6 points, and referrals to community resources is worth 3 points. The Track and Coordinate Care standard accrues 18 points in the following elements. Test tracking and follow-up is worth 6 points. Referral tracking and follow-up is worth 6 points. And coordinate with facilities care transitions is worth 6 points. And finally, the Measure and Improve Performance standard accrues 20 points in the following elements. Measures of performance is worth 4 points. Patient family feedback is worth 4 points. Implements continuous quality improvement is worth 4 points, and demonstrates continuous quality improvement is worth 3 points. Performance reporting is worth 3 points, and report data externally is worth 2 points. The total amount of points is equal to 100. The Accountable Care Act created accountable care organizations. Accountable care organizations refer to physicians, hospitals, other providers, and service suppliers that have agreed to work together to coordinate patient care under the original Medicare program. While working to provide these coordinated services for Medicare beneficiaries, the provider groups establish a mechanism for shared governance and strive to provide high quality and coordinated care. ACOs are recognized legal entities at the state level and are therefore bound by state law. The Centers for Medicare and Medicaid Services, CMS, the entity that administers Medicare, will enter into 3-year agreements with an ACO, and the ACO then assumes responsibility for the coordination, cost, quality, and overall care for the assigned Medicare beneficiaries. Cost savings are to be shared across the ACO partners. According to the rule, Medicare would continue to pay individual providers and suppliers for specific items and services as it currently does under the fee-for-service payment systems. The proposed rule would require CMS to develop ACO-specific level of savings which need to be achieved by each ACO if the ACO is to receive shared savings, as well as level of losses realized by an ACO if it is held liable for losses. Additionally, an ACO is accountable for meeting or exceeding the quality performance standards to be eligible to receive shared savings. Overall, the goal of the ACO is to reduce the cost of care while improving quality of care coordination for Medicare beneficiaries. Care decisions are shared between the providers and the patient in an ACO, thereby in addition to improving quality and increasing cost and efficiency, and the ACO would also contribute to a patient-centered orientation to care. In summary, it is clear that the quality of care received in the United States needs improvement. In the current healthcare environment, there are a number of initiatives that aim to improve the care for all Americans through the use of IT, and we covered content related to each of these programs. Meaningful use of health information technology was one, patient-centered medical homes was another, and finally, we described the requirements of accountable care organizations under the Centers for Medicare and Medicaid Services.